Presenting on behalf of Medicine 5. Presenting a 22-year-old lady from Tiruvannamalai. She presented to us with complaints of weakness of the lower limbs, which started at 6 years of age and progressed to involve the upper limbs as well. She was unable to turn in bed from side to side or turn her neck since 12 years of age. And currently at 22 years of age, she had presented to us with complaints of fever, cough, and breathlessness for the last 4 days. She was born to parents of a 4th-degree consanguineous marriage. Her antenatal period was uneventful. There was no birth asphyxia. And she was apparently developmentally normal till 6 years of age. At 6 years of age, her school teachers first noticed that she had difficulty in climbing her stairs. She required 2 of her classmates to support her by the arms when she was climbing her stairs. And they also noticed that when she was sitting cross-legged on the floor, she had to push herself up onto the knees and to stand from sitting on the floor. They noticed some instability while she was walking. She was noted to be predominantly walking on her toes with the knees slightly bent. She was noted to have a prominent abdomen while she was walking with the compensatory pullback of her shoulders. She also had frequent falls. By 7 years of age, she had frequent buckling of the knees, and by 8 years, she had complete weakness of the lower limbs with only a minimal movement at her toes. Her family also noticed some thickening of the calf muscles. At 9 years of age, she developed difficulty in dressing herself. This was followed by difficulty in writing and mixing her food. The upper limb weakness gradually progressed till at 12 years of age, she only had a flicker of movement at her fingertips. She was unable to turn in bed from side to side or pull herself to a sitting position. And by 14 years of age, she was completely bedbound. She did not have any complaints of diplopia. There was no loss of sensation over the face, no difficulty closing her eyes, chewing or swallowing her food. There was no dribbling of water from the sides of her mouth. She did not have any hearing loss and her speech was normal. However, she did have difficulty in turning her head from side to side. She was able to feel hot and cold water over her body and was able to perceive sensation of her clothes. She had normal bowel and bladder habits. She did not have any symptoms of autonomic dysfunction, and she did not have any intellectual disability. Even after she was bedbound, she continued her studies at home. Her current admission was for 4 days of high-grade fever with chills, cough with whitish sputum, and breathlessness. Summarizing her history, she has presented with a pure motor syndrome with childhood onset bilaterally symmetrical, progressive, proximal more than distal weakness with bilateral sternocleidomastoid weakness and no sensory autonomic involvement and no intellectual disability. She has also come with a second problem of fever for 4 days with localization to the lower respiratory tract. Her examination findings, she was tachycardic and tachypneic on examination. She had a talipes varus deformity of the bilateral feet. There was no significant muscle wasting noted. She had macroglossia and calf hypertrophy. Her respiratory examination showed bilateral V's and basal crepitations. CNS examination, her ocular movements and optic nerves was normal. Fundoscopy was also normal. She was noted to have weakness of mouth opening, but she had normal sensation over the face. She had weakness of bilateral seventh nerves with weakness of the buccinator and orbicularis. She was also unable to turn her head or shrug her shoulders. The rest of the cranial nerve examination was normal. Motor examination, her bulk was normal bilaterally. She had hypotonia of all 4 limbs with absent power. There was only a flicker of movement at the fingers and toes, and there were no fasciculations noted. Her sensory system and cortical examinations were all normal. Deep tenon reflexes were absent in bilateral upper and lower limbs, and superficial abdominal reflexes were absent as well. Her anal tone was reduced. Plantars were flexor bilaterally. Cerebellar signs were not assessed. So summarizing her history and examination, again, she's come with a pure motor syndrome with childhood onset bilaterally symmetrical progressive element type of weakness in view of absent reflexes and flaccidity, which is proximal more than distal with weakness of the motor component of the 5th, 7th, and 11th cranial nerves with no sensory or autonomic involvement. So the localization, so she has features of a element syndrome, pure motor syndrome with localization to the lower motor neurons. The localization could be anywhere along the lower motor neuron from the anterior horn cell to the nerve roots, the nerves, the neuromuscular junction, or the muscle. Historically, she did not have any history of diurnal variation of fatigability, so neuromuscular junction was less likely. There was no sensory involvement, so nerves were less likely as well. And the pattern of involvement was a bilateral symmetrical ascending pattern of weakness, which makes the involvement of the nerve roots less likely. Both anterior horn cell and muscle are possible localizations. The fact that she had absent reflexes is more suggestive of an anterior horn cell disease because in myopathies, usually the reflexes are preserved until late in the disease when the muscles are completely atrophied. However, in addition to this, she also had features of proximal more than distal weakness, and she also has involvement of the striated muscles of the face with sparing of the smooth muscles. Her gag reflex was normal. So now the localization becomes a pure motor syndrome with localization to the striated muscles. And the etiology, given the slow progression over years, points to a muscle dystrophy rather than a myositis. So the possible muscle dystrophies we considered were Duchenne and Becker's muscle dystrophy, but both of these are X-linked dystrophies, so they're unlikely in a female patient. Duchenne also has significant mental impairment. The other dystrophies are oculopharyngeal. However, in this, the first symptom is usually paralysis of the extraocular muscles, which is unlikely in our patient. Facioscapulohumeral, the pattern of involvement is usually proximal more than distal in the upper limbs, but in the lower limbs, it's a distal more than proximal weakness, which does not fit our patient's symptoms. Myotonic dystrophy usually has very severe intellectual disability, and again, the pattern of weakness is distal more than proximal. Emery-Dreifuss is possible. The only thing against it is that they usually have early onset contractures, predominantly upper limb contractures. The classical triad in Emery-Dreifuss is cardiomyopathy, early contractures, and proximal more than distal weakness. Limb girdle muscle dystrophy fits a patient's profile with the absence of intellectual disability and the absence of any features of heart failure. There are over 20 different types of limb girdle muscle dystrophies. All of them have in common is a proximal more than distal muscle weakness with no intellectual disability. The differences among the types is whether there is involvement of that's associated cardiomyopathy, the age of onset, and the severity of the muscle weakness. So among these types, there are 4 types that fit our patient's clinical profile. These are the laminin gene mutations, sarcoglycan gene, fukutin gene, and titin gene related. So final differentials are a probable limb girdle muscle dystrophy with these possibilities and currently with the community acquired pneumonia. Her investigation showed a total counts of 8,800. Her LFT and RFT were normal. CPK was 137, although she did have an outside report from 3 years prior, which showed a CPK of 687. Her myoglobin was within normal limits. TSH and cortisol were normal. Her EMG showed no spontaneous activity in both proximal and distal muscles. We had also sent a next generation sequencing panel for all possible limb girdle muscle dystrophies, which showed a mutation in the sarcoglycan gene. So our final diagnosis was a limb girdle muscle dystrophy, sarcoglycanopathy, and a community acquired pneumonia. So coming to sarcoglycanopathies, these are a group of autosomal recessive muscle dystrophies. They're caused by a missense mutation in the sarcoglycan proteins. They're characterized by progressive muscle weakness, respiratory muscle weakness, and usually death by the 2nd to 3rd decade of life. So these are the sarcoglycan genes. So in the myofibril, the function of the sarcoglycan proteins are to provide stability to the plasma membrane. Within the myofibril, you have the actin and myosin filaments. These are then attached to the plasma membrane of the myofibril. So every time there is a muscle contraction, the stress is transmitted to the plasma membrane of the muscle. So in the absence of this structural support of the plasma membrane, the repeated contractions can cause rupture of the plasma membrane and lysis of the myofibrils. In order to prevent this, the main protein preventing this is the dystrophin and dystroglycan complex. This is attached intracellularly, it is attached to the actin filaments. Extracellularly, it attaches to the laminin and the extracellular matrix. So because of this protein, the stress of the muscle contraction is transmitted to the extracellular matrix and not to the plasma membrane of the cell. Sarcoglycans are not directly attached to the actin or to the extracellular matrix, but they provide a scaffolding support to the dystroglycan proteins. There are 4 different sarcoglycan proteins, alpha, beta, gamma, and delta, and the mutation in any of these causes weakness of the dystroglycan complex. So these so normally these sarcoglycan proteins, they're synthesized intracellularly, and then they're transported to the plasma membrane where they're integrated into the cell membrane. The problem in sarcoglycanopathy is a missense mutation in these sarcoglycan proteins. These are then identified by the endoplasmic reticulum and the proteasomes, and they get degraded before they are allowed to integrate into the cell membrane. But even though there is a missense mutation in these proteins, they still retain a certain degree of functionality. So if they if they were prevented from degradation by the endoplasmic reticulum and they were allowed to integrate into the plasma membrane, they would still provide structural support to the plasma membrane and prevent the degradation of the myofibrils. So the current therapies are all targeted at preventing proteasomes from degradation of the sarcoglycan complex. Bortezomib is the prototype drug. It is already in use for multiple myeloma. In tumor cells, it prevents the degradation of the pro-apoptotic factors by the proteasomes and causes tumor lysis. The same drug is being trialed in the treatment of sarcoglycanopathies to prevent the degradation of these misfolded proteins. Currently, however, there are no treatment options available. This is currently only in phase 2 trials. So take-home points are to keep in mind pure motor element syndromes. Localization may be anywhere along the anterior horn cell, roots, nerves, neuromuscular junction, or muscle. to identify based on the pattern of muscle weakness and the types of muscle dystrophies. Thank you.
Any questions or comments? Then we'll go on to the next one.